Good morning, good afternoon to you all. Thank you for joining us for today's webinar on pre-qualification of Mpox vaccines and its implications. I'll quickly take us through some housekeeping. Today's webinar, the objective is to provide an update on the pre-qualification of Mpox vaccines and also share an update on the supply outlook and the access and allocation mechanism. We also want to discuss with you Mpox vaccine strategies that can be adopted by countries based on epidemiology in your respective countries. But before we start, just to remind you that this virtual training adheres to the Code of Conduct to prevent and respond to sexual misconduct, including sexual harassment, abuse, and exploitation. And for your information, we have these functions. I think you can see these on your screens, the Q&A chat box. As we go along, as we go through the presentations, please feel free to put all your questions in the Q&A chat box, and the panelists will continue to respond to these questions as we go along. But in case you want to ask your question directly to the panelists, we'll have a Q&A session where you'll be able to raise your hand, and then they'll give you rights to be able to ask your question directly to the panelists. We also have the general chat box where you can put any other comments, and also utilize the chat box to tell us where you're joining us from or any other information that you would like to put across. We also have the reactions icon, and most importantly, we also have interpretation for this session. We have interpretation in 3 languages, English, French, and Portuguese. So feel free to click on the interpretation icon and choose the language you're most comfortable with. And you can also type in the chat in whichever language you're comfortable with. As I already mentioned, please use that Q&A chat box for us to be able to save time, but also to respond to most of your questions. We'll try our best to make sure that we respond to all your questions. The interpretation icon, once you click on it, you'll see the 3 languages that are available for this webinar. We also have the captions, the show captions icon. In case you want the captions, you can click on this icon. The webinar is being recorded, and the recordings and the materials from this webinar will be shared after this webinar. We also value your feedback. Please, we'll share a survey at the end of this session, and we request you and encourage you to share your thoughts and suggestions, as this will help us for future sessions. Thank you very much. So as we begin our session today, on agenda, we'll have opening remarks from Dr. Samuel Boland, who is our incident manager for the regional IMST here at WHO Afro. Then I'll quickly share some highlights on vaccines introduction, specifically on the strategy and what we are looking at in the region. Then we'll have one of the experts from WHO HQ team taking us through the access and allocation mechanism and how this works. Then we'll also have a presentation from colleagues from HQ, Carmen, Marie, telling us about pre-qualification of Mpox vaccines and facilitated product introduction. We'll take all the presentations first. They are all short presentations, and then we'll have the Q&A discussion after that. But as I mentioned, please feel free to type your questions in the Q&A chat box, and we'll keep responding to these as we go along. Then for those who would like to ask directly, we'll have a Q&A session after all the 3 presentations. The webinar is 1 hour, and we look forward to a lively discussion with you. Thank you once again for joining. I'll request Sam to quickly give his remarks, and we delve into the session.
Thanks so much, Sheila. It's much appreciated. Hello, everyone. Good morning, and thanks for joining today's critical webinar on the pre-qualification of Mpox vaccines and what that means for the African region. It's, of course, a critical moment for our collective response to Mpox, particularly here in Africa, where the long wait for access to vaccines has been deeply felt. The pre-qualification of these vaccines marks a very significant step in ensuring that we have the necessary tools to combat this outbreak effectively. While challenges remain around vaccine supply and other regulatory issues, this milestone moves us closer to ensuring that vaccines that are available are safe and are effective. And it's a key step in our effort collectively to provide countries with a reliable tool amongst the wider public health toolkit to respond to Mpox outbreaks and safeguard populations. In addition to this pre-qualification, the World Health Organization has developed the access and allocation mechanism, which is designed to ensure that vaccines are distributed equitably across the region based on need and operational risk. This is particularly important in a context where these supply constraints are very real and where we need to prioritize readiness and response in the countries most at risk. I want to be sure to take a moment to recognize and thank all of you for your continued dedication. Whether you are dialing into this webinar as a representative of a national health authority or a non-governmental organization partner or a WHO colleague or any other person, your efforts are fundamental to ensure that we can effectively advance these key strategies and bring the outbreak under control and ultimately to save lives. I look forward to today's discussions. I hope they will provide you with valuable insights as we continue to work together to strengthen our response. Thank you, and back over to you, Sheila, to begin the first session of this webinar.
Thank you very much, Samuel. So I think he has provided very good preamble for especially all our presentations, and I'll go straight into sharing some of the considerations for Mpox vaccination in the African region and what we are currently looking at. So as we are all aware, the Mpox outbreak was declared a fake due to an increase in cases that were being reported in DRC and neighboring countries in August of this year. And as we also know, smallpox was eradicated through extensive immunization campaigns, both routine immunization and targeted vaccination during outbreaks. Smallpox vaccination showed cross protection against Mpox. And since 2022, there's been an increase in Mpox cases, and this is probably associated with the declining immunity to orthopox viruses, since vaccination against smallpox has since been slowed down. In this year of 2024, we've had 16 countries that have reported cases of Mpox, and we know that immunization is one of the tools to stop disease transmission, in addition to the other effective interventions like WASH interventions and also case management. In terms of strategy, we are currently following the SAGE guidelines. The Strategic Advisory Group of Experts on Immunization released recommendations on the use of Mpox vaccines in March of this year, and these were updated in August of 2024, including for use in outbreaks. And the current recommendations is that we vaccinate persons at high risk of exposure to Mpox in an outbreak, and allowing great flexibility with respect to local risk assessment, varied modes of transmission, and also response options. Based on local epidemiology, we can vaccinate members of a geographically defined area or community, including children, with a documented high risk of exposure to Mpox. We can also vaccinate healthcare workers at risk of repeated exposure. We can also vaccinate contacts of persons with Mpox, ideally within 4 days after exposure, and then also other risk groups like the sex workers, gay, bisexual, and other men who have sex with men, or individuals with multiple casual sexual partners. So these are the current SAGE recommendations. Looking at available, the SAGE also recommended use of these 3 vaccines, the MVA-BN, LC16, and the ACAM 2000. So looking at the vaccines that were recommended for use by SAGE, the MVA-BN, currently we have some efficacy data from MVA-BN, which shows effectiveness of around 76% for 1 dose and 82% for 2 doses. And we still have gaps in data from the other vaccines, and we continue to make sure we close these gaps and are able to effectively use these vaccines. The SAGE also defined choice of vaccines for different at-risk populations. And as we can see from this table, the MVA-BN, which is non-replicating, was recommended for adults above 18 years and infants and children and adolescents below 18 years. In the US, the MVA-BN has emergency use authorization for children below 18 years. It was also recommended for use among pregnant women as off-label, and also among immunocompromised groups like people living with HIV and other groups like those with atopic dermatitis. The LC16 is minimally replicating, and it was recommended for adults above 18 years and children below 18 years. It is, however, contraindicated for these other groups, along with the ACAM 2000 as indicated. So currently we have 2 vaccine products that are currently under discussion or available to us to use in the region, that is the MVA-BN and the LC16. Looking at the vaccination strategy, we have the Global Strategic Preparedness and Response Plan, which outlines a vaccination strategy. And this is the recommendation is to do this vaccination in phases. Phase 1, which we are particularly focusing on given the limited supply of the Mpox vaccines, is to stop the outbreak. So phase 1 is to stop the outbreaks and interrupt chains of transmission by targeting contacts of incident cases with onset in the previous 2 to 4 weeks. If we target areas where we are getting incident cases reported in the past 2 to 4 weeks, we are likely to interrupt transmission because we know there is active transmission going on in these places. And still in these places, would like to also target healthcare workers or frontline healthcare workers who are also at risk. Then phase 2 will be to expand protection, and this will look to limit further spread in affected communities, and it will be targeting individuals at high risk of severe disease. But phase 2 and phase 3 will get there once we, as vaccines become more and more available. But for now, the focus is to stop the outbreak with the limited available vaccine doses. Phase 3 will be to protect the future by increasing population immunity in areas at risk of outbreak expansion and future outbreaks. And we could also consider endemic areas. We also have the Mpox Continental Preparedness and Response Plan for Africa. This was jointly developed by Africa CDC and WHO. And really the strategy is the same. And the phases, it outlines 2 phases, first phase and second phase. And the first phase is to still vaccinate exposed groups of contacts and contacts of contacts, and then expand these to include the healthcare workers and immunocompromised groups and key populations. And then during the second phase will be to expand to the wider population groups. So as I mentioned, we are focusing on phase 1 to stop the outbreak, but to be able to do this effectively and also to target effectively, we need to understand epidemiology at the local level. We need to have good data and in time to be able to map hotspots or know which people are affected and where they are for us to do good targeting. And so we need to make sure we have data, and we are really looking at our data to guide our vaccination strategies as we have limited supply of vaccines. This will also help us to effectively plan our operations. And as you may be aware already that WHO pre-qualified the first vaccine against Mpox, the MVA-BN, in September. And there is ongoing review of other manufacturers' dossiers as they keep submitting their information for review. The MVA-BN vaccine can be administered to people in over 18 years of age as a 2-dose injection given 2 weeks apart. It can be kept at 2 to 8 degrees Celsius for up to 8 weeks. It's available data, as I already mentioned earlier, estimates effectiveness at around 76% for 1 dose and 82% for 2 doses, and has demonstrated a good safety profile and vaccine performance from recent clinical studies and also from real-world use. It has been widely used during the ongoing global outbreak since 2022. The pre-qualification, we hope, will help us to accelerate procurement of vaccines by the government, international agencies, and alongside other preparedness measures. And due to the long-standing country experiences with pre-qualification processes, this may help with accelerating regulatory review of this product by governments through process of reliance and recognition. However, the government still need to go through the regulatory approvals and review the product, review the vaccine dossiers according to their established procedures, and pre-qualify the vaccine before it is imported and used. We need to continue with preparedness in countries by clarifying the regulatory pathways and also identifying requirements for importing the vaccines and having this in place to be able to facilitate importation of these vaccines. We have the AVARIF platform, which can provide support to and is already providing support to countries in navigating some of these regulatory processes. And we have someone on this webinar who will talk more about this. Pre-qualification also allows international agencies like Gavi and UNICEF to procure the pre-qualified product, in this case, MVA-BN. And we have the access and allocation mechanism, which has many partners that Tim will talk about right after my presentation, that is available to make sure there is equitable access to available vaccines. In order to ensure regulatory preparedness, countries need to continue to ensure some of the key preparedness activities, like engaging the NITAGs to develop strategic Mpox vaccine recommendation, Mpox vaccine use recommendations to guide the countries on how to move forward with Mpox vaccination, and then developing national deployment and vaccination plans and costing these plans so that we are ready to receive the vaccines as they become available, because these processes also take a bit of time. Currently in the region, a few countries have received some Mpox vaccine doses. We have DRC, Nigeria, and Rwanda that have received vaccines, and currently these countries are planning to roll out vaccination. So in addition, we have a few tools that can help countries as they prepare for or navigate the deployment. We have a library guide, a one-stop shop webpage located on the NITAG support Support Hub, the niche, for supporting countries with decision-making through their NITAGs. And there's a snapshot of this library. It's an online library and free access. It is user-friendly, and it provides a rapid review focusing on Mpox vaccines' efficacy and effectiveness, and is regularly updated with the most up-to-date information. It is also a gateway to access relevant Mpox published resources. So if you need any of latest information, please visit this library. It's a joint effort from the NITAG support partners, that is University of Cape Town, USCDC, WHO, and the Task Force for Global Health. We have also developed a roadmap for Mpox vaccination preparedness, which we shall be sharing with countries. This is ready, and it will be a tool to guide countries on some of the key activities or things need to be put in place as we prepare for vaccine deployment. We also have, as we introduce the vaccine, we have gaps in safety data, but also being a new vaccine, we need to make sure that we strengthen our safety surveillance for the vaccine. And we have some of these tools that are available for us to use. And we encourage countries also to use protocols to be able to continue with safety monitoring and surveillance. So these slides will be shared with you in case you need any of these tools. You can follow these links to be able to access the tools. Some of the other tools that are in development and will be shared with countries very soon are training materials for MVA-BN and LC16 for countries that are ready to roll out vaccination, and then vaccine explainers, fact sheets, and other communication materials for debunking vaccine misinformation. Thank you for listening. This brings me to the end of my presentation. Please feel free to put your questions in the chat as we go along. We shall make sure we answer or respond to all your questions. Please type them in the Q&A chat box, because in the general chat, they may get lost in so many comments, but specifically put your questions in the Q&A chat box. We'll go straight into the next presentation. We'll have the Q&A session after all the presentations. So next will be Tim.
Thank you very much, Sheila, and hello, everybody. Happy to be here and give you a brief update on the Mpox access and allocation mechanism, and give a brief outlook on where we're standing with supply at the moment. Next slide, please. So first of all, I want to introduce you that we have a so-called interim medical countermeasures network platform, where we're bringing in all the relevant partners globally together to support helping us improve the end-to-end value chain in the MCM ecosystem. What we mean by this is equity starts already at the upstream part, where you do the appropriate R&D for those medical countermeasures where we see a huge gap. And then this trickles down to really to improve scalable and localized manufacturing capacity, then goes to the part of how do we procure access, coordinate demand around countermeasures during emergencies, and how do we do strategic allocation, and then how do we ensure that all these products, vaccine, diagnostic, and treatment, go to the last mile. Diagnostic needed for improving our surveillance, vaccine to protect our communities, and treatment to ensure safe and clinical pathways in communities. So I think you see here an end-to-end value chain that then ensures that we have effective, quality assured, and affordable and timely access to these countermeasures. And this requires a multi-partner approach with the partners that exist globally. And we're currently about 50 partners that join this IMCM Net coordination platform. And we're applying this now to the Mpox response. So next slide, please. So on these three key pillars on R&D, manufacturing, and supply chain, we have different forums where partners come together to improve the system. We held end of August an important scientific conference to look at the research gap we have around Mpox, and these are the key partners came together and they have agreed on 10 priority actions in the R&D field that now the partners take forward. We're discussing with different partners, about possibility of scalable and localized manufacturing capacity, including technology transfer. This is an important part, but this is something that takes some time. So these are medium to longer term strategies to improve, production of Mpox products, more to the local level, but also to expand this to more manufacturing capacity in the mid and long term future. But most urgently, we have been working with partners to bring together the AAM, the access and allocation mechanism, that must do three things. First is really to aggregate the global demand, but at the same time, really work with the countries to assess what is the current demand in countries to face the current outbreak. Secondly, to coordinate and increase access to these supplies, either through donations from member states or countries that have stockpiled these countermeasures, but also in addition, to secure funding to procure more of this directly by the manufacturer. And thirdly, to build an equitable and fair mechanism to strategically allocate those limited resources so they have the best public health impact to the current situation. So these are the three tasks of the AAM. Where do we stand currently? Next slide, please. Where we stand currently is really we have built a coordination platform around the key partners in the access allocation field. These include WHO, UNICEF, Gavi, CEPI, most importantly, Africa CDC, where the burden is now high, but also including the European Union, the HERA, the unit defined. So these are the key partners along the entire value chain. And this is where we bring the key partners here together. Where do we stand now at the supply? We have different supplies coming through direct procurement. So UNICEF and Gavi have secured now about 1 million doses through those contractual agreement with the manufacturer. We have different country pledges are coming in. Some of these are direct bilateral donations from one country to another, and others are now pledges that go to the AAM for the AAM to then do the strategic allocation. So the global count stands now at around 5.9 million doses of Mpox vaccine, both at the MVABN and the LC16. So, a considerable amount here is through country-to-country pledges, but we are currently standing around 2.5 million doses that have been pledged to the AAM partners and the AAM mechanism. And this is the amount then where the mechanism will then be working on allocating this strategically to the different demands that are coming in. Next slide, please. So I really would like to iterate and explain a bit the process, how these things will be handling. I think first of all, and I think building on what Sheila, my colleague, already said previously. First of all, vaccination must be part of a comprehensive response strategies. So when countries are requesting a vaccine, this will be assessed against a comprehensive strategy to control Mpox in the country. That must include enhanced surveillance and case finding. That must include community engagement and risk communication. That must include contact tracing and public health and social measures, must include community protection, health promotion, must include safe and scalable care. Vaccine is not a silver bullet. It needs to become as a comprehensive strategy. I think that's the first requisite, and eligibility, you must demonstrate this. Secondly, in the next 6 months, this vaccine must be used as part of outbreak control strategy. So Sheila presented the 3 vaccination or control phases, and really we are looking and targeting right now in the next 6 months to stop the outbreak, vaccinating in hotspot areas, the context of index case, and of course the healthcare workers and frontline workers working in these hotspot areas. So I think this is important, that this limited supply is used in a targeted approach in the next 6 months, and that's the focus then of the AAM to allocate, these vaccines. What countries need to do? Countries need to request vaccine with a comprehensive response strategy, including a vaccination plan that needs to go to the continental IMST. This is where the assessment is being made. This is where the continental IMST will support countries in improving their response and vaccination plan, and have a full dossier complete to be assessed by an independent review committee. We will be establishing, an expert group that then can evaluate these country requests and make an evidence-informed, evidence-based recommendation on how to best allocate these limited supplies. And then these are being released, and then countries are supported in the rollout of this, that as part of a comprehensive strategy and as part of a targeted vaccination strategy. So I stop here. Back to you, Sheila.
Thank you very much, Tim, for elaborating on the access and allocation mechanism and what the supply at global level looks like right now. Again, we'll not be taking questions right now. We still have just one more short presentation, and then we'll be taking all your questions to any of the panelists. But in the meantime, you can also put any of your questions in the Q&A chat box. So I'll call upon Marie and Rodriguez.
First, it will be Carmen's presentation, please.
So while you project the slides, thank you for inviting us for this workshop. I'm Carmen Rodriguez, and I'm leading the vaccine pre-qualification team, and also the team in charge of the emergency use listing. Next slide, please. Then this is just to outline the two processes that we have in WHO. The pre-qualification that was developed in 1987 as a way to provide advice to UN procuring agencies on the acceptability for international procurement, and the emergency use listing that was developed following the Ebola outbreaks in 2014-15, and that was later revised in 2020 that was successfully used during the COVID-19 pandemic. Both processes, I just want to highlight the differences are that in the case of the PQ, is based on a review of extensive quality, safety, and efficacy data, and the added value of the work that WHO does is to ensure the programmatic suitability in low, middle-income countries. In the case of the emergency use listing, we are talking about is a risk-benefit assessment of essential set of quality, safety, and efficacy data for use during a public health emergency of international concern. In both cases, the assessment is done by WHO independent experts, and we rely on in both cases, on the WHO-listed authorities, in the case of AAA for abbreviated process, and of course, and we focus on the programmatic suitability, and also for the emergency use listing, we have this approach. Another difference with the emergency use listing is that because the product or the data is not yet, let's say, fully generated, we need to have, it's very critical, the post-deployment monitoring. This will be a time-limited recommendation. The manufacturers may need to generate additional data to allow a marketing authorization and later pre-qualification. Next slide, please. This is showing what we did in the case of Mpox. And this, everything started when the WHO Director General triggered the emergency use listing. And this was one of the preparatory activities. We developed a call for expression of interest on 9 August 2024. And when the phase was declared on 14 August 2024, manufacturers submitted this expression of interest. At the same time, as the preparatory activities, we established a strategy for having an expedited recommendation for these vaccines. And we discussed, when the manufacturer submitted the expression of interest, we discussed in pre-submission discussions the data that was available, and we also prepared legal agreements that will enable WHO to share information with relevant authorities in low middle income countries. Then we have in this particular case, it was mentioned before that we have the NBA Bavarian Nordic submitting a dossier. Let's say that as part of this expression of interest, a call, KMB also submitted a dossier, and both of them submitted full data on 23rd of August. And we also received an expression of interest from Emergence for the ACAN 2000. So we discussed with the relevant authorities that are in charge of the oversight of the products. We established the product evaluation group, and we review the data, the CNC, the clinical, the risk management plan that is really relevant to ensure that this considers the needs of low middle income countries, and of course the programmatic suitability aspects that are also relevant to countries. Reviewing the data, because we have a product evaluation group, and then we have a technical advisory group. That is the group that is doing the risk-benefit assessment in case of the emergency use listing, the review of the data submitted by Bavarian Nordic. The experts indicated that we can proceed for pre-qualification pathway, and this was based on as well of the approval of the National Regulatory Authority of Reference, that in the case of Bavarian Nordic is the European agency. In the case of the KMB, that is a Japanese manufacturer producing the LC16, we are following the risk-benefit assessment as indicated before, that is also called EOL. So we have, in the case of Bavarian Nordic, we follow the recommendation of the experts, and we pre-qualified this vaccine on 13 September 2024. So we follow a very fast assessment process of the vaccine. And this vaccine, as indicated before, is pre-qualified for use as from 18 years of age. As part of the post-PQ changes, we are now reviewing the data. The vaccine was authorized. It was extended, the EMA extended the age indication from 12 years of age, and this is under review, and we expect to pre-qualify this age indication early next week. And of course, we have also other post-PQ changes that need to be submitted for, let's say, WHO PQ evaluation. In the case of Bavarian Nordic, we also pre-qualified this vaccine with some conditions, because, and as you may have seen, the vaccine the brand name is Imvanex, the one approved by EMA. However, there are other two brands. One is the Genius, that is under the oversight of US FDA, and the Invamune, that is under the oversight of Health Canada. We discussed with those authorities, and we included because they are the same vaccine, but in the case of the Genius, the vaccine has a storage condition of, according to what US FDA approved, is 4 weeks up to 8. However, we review the data and we recommend the countries. These countries need to decide the use of this vaccine if they receive via donations the vaccine genius that the countries may use this vaccine, follow the EMA and the PQ recommendation of storage of the vaccine at 2 to 8 for 8 weeks. As for, let's say, all pre-qualification aspects, we need, and in the case of the UL, for in the case of KM, we need to have implementation of strategies for safety, quality, and effectiveness monitoring. And of course, in the case of the UL, the manufacturer needs to provide data for allowing the pre-qualification. The last vaccine that is there, that is emerging, is the ACAN 2000. We receive an expression of interest that is currently, let's say we are drafting the legal agreements with the company and they are submitting the data very soon. So we are going to do the review of that, the information, and we will decide the pathway that we are going to follow based on data available. And this is what are the principles of the emergency use listing and the pre-qualification that is based on the data, quality, safety, and efficacy data, and of course, the programmatic aspects. Next slide, please. This is just to highlight the challenges that with these vaccines that the low middle income countries will face. The first one is about what I mentioned before about the shelf life at the freezing conditions, and of course, the storage condition at 2 to 8, because the country may need to ensure that, and this is something like it's not in compliance with the critical programmatic suitability criteria, that the countries may need to store the vaccine to extend a little bit the remaining use of the vaccine, to store the vaccine at -20, and then later to plan very well the campaigns to store the vaccine at 2 to 8 for only 8 weeks, because this will be, and we face the same situation during COVID times. Regarding the one important point is the use of bifurcated needles. That is the way that the vaccine, the LC16 and also the ACAN 2000 is used. That there are some challenges because in fact, this will require healthcare worker training. So the countries may need to prepare to be ready to administer the vaccine following this technique. And of course, one additional point, and is connected with one of the other values of the PQ work, that is the multi-dose vial policy, that where there is a risk of contamination of open vials, and this is something that we are going to consider when we do the listing under the emergency use listing of this, the LC16. I think that this is the last slide from my side, and then Marie is going to comment on what are the options that are foreseen for the facilitating in countries authorizations. Over from my side.
Thank you so much, Carmen, and good afternoon to you all. Thank you very much for the organizer to invite us to present a few slides regarding the option for facilitation of emergency use authorization in country. My name is Marie Valentine, and I'm the team lead for the team Facilitated Product Introduction at WHO headquarters in Geneva. So our team support member states with all the reliance mechanism to facilitate authorization and registration of quality assured medical products. So we support the WHO collaborative registration procedure, all the regional joint assessments, and also the global health product procedure, such as the EUM for all or marketing authorization for global health product from Swissmedic. If we move to the next slide, please. So for the Mpox vaccine, reliance is at the core of the response, as was done also for COVID-19. So we just want to remind you of a few principles. So we're trying to reduce duplication where possible. We try to put the resources where they are most needed, so to use a risk-based approach in terms of evaluation. And we want to maximize and utilize the reference and the work done by other authorities or by other institutions like WHO Prequalification. So really, we are looking at trying to find the fastest and robust emergency use authorization in countries and to avoid duplication or delay. What we are trying to promote as well is informed reliance. So we try to, for the countries to have as much as possible all the relevant quality, safety, and efficacy data to make their decision. And Kwasi is on the call, and I know that under the AVRF joint review, the countries have signed confidentiality agreements to access some of the manufacturers' dossier where the manufacturers has accepted to give consent to share the dossier. We also use reliance, and we encourage the use of reliance for other regulatory functions. So we're thinking, for example, at the batch release, the official batch release, so try to not to duplicate the testing when it's not necessary, and also in terms of pharmacovigilance to share the data, etc., etc. So reliance is not only for the initial authorization, but it's also for other regulatory functions like post-authorization changes, the batch release, and pharmacovigilance. Next slide, please. So this is the status. So we've just tried to outline the status of the 3 vaccines. And they have obtained some authorization in some of the countries. As Carmen has clearly highlighted, the MVABN has just been pre-qualified on the 13th of September for the adult indication. But as Carmen has mentioned, we are expecting the extension of indication for adolescents in the current of next week. The LC16 is under evaluation from the pre-qualification team. What we are trying to propose, so many of the countries are participating and have joined the collaborative registration procedure. So we know that for countries where an application is planned, but we know that no application as far as we know, and we please ask countries if they are approached by any manufacturer for submission, please liaise with us, and we will be happy to facilitate the collaborative registration procedure. So, for example, for the MVBN that is authorized by the European Medicine Agency, they have confirmed that they will be happy to be the SRA and to do SRA CRP for this vaccine. We know that in many countries there wouldn't be an application. So what we are proposing is to facilitate the decision in country and the issuance of the emergency use authorization by providing the PQ and the EUL reports to NRS to facilitate their in-country decision. So we're working closely with Carmen's team in terms of having the assessment report. Obviously, this has to be done under confidentiality agreements with the manufacturer. So we are waiting for some of the manufacturer to give us the legal permission and get the green lights to share this assessment report. But we will be happy to facilitate provision of those reports to facilitate the in-country decision. And I think with that, I will leave it as this for now. And I think as our colleague Kwasi is on the line from the AVRF Secretariat. And I think, Kwasi, you want to say a few words on the AVRF joint review. Thank you very much.
Sheila, you're muted. If you're speaking, we cannot hear you.
Oh, sorry about that. I was saying that we have a few minutes left to the end of our webinar. So, Kwasi, I give you 1 to 2 minutes to say something about AVRF.
Thank you very much. Can you hear me?
Yes, very well. Thank you, Kwasi.
Okay. Yes, no, as was said, the 14 or 12 countries for which it hasn't been as authorized as yet got together and are using the AVRF platform. They have access to the same information. At the time that we started, it had not been pre-qualified, but the Bavarian Nordic was grateful enough to provide us with the dossier. We also had the assessment reports from the US FDA, as well as the European Medicines Agency. And these reports, as well as the dossier, has been reviewed. The review started. Questions were provided to the company. The questions have been submitted. And actually, we expect to start the actual joint review next Monday. And so it's ongoing, and in the coming days, we will be having the decision for all the countries involved. Thank you very much.
Thank you very much, Kwasi. Thank you all for staying with us until now. We are opening the Q&A session, and I'll be starting with those who have put up their hands to ask questions to the panelists. In case you have any questions, please go ahead and raise your hand, and I'll be calling upon you to ask your questions. But you can also type your questions in the Q&A chat, and the panelists are already addressing these questions. To the panelists, please go into the Q&A chat box and respond to some of the questions directed to your presentations. So I'll start with the hands that are raised now. I'll start with Adam Sanogo. Please unmute your mic and ask your question. Adam, are you able to unmute? Okay.
All right.
Adama, please.
Good morning, all.
Yes,
Can you
good
hear me?
morning. Please go ahead.
Yes, this is Nasir calling, joining from Zamfara State, Nigeria. My questions are as follows. Thank you, the presenters, for this insightful presentation. I'm asking from on epidemiology and data-driven strategies. How is the current epidemiological data influencing Mpox vaccination strategies across different regions? Are there specific data points that countries should focus on to develop tailored vaccination approaches? Just to guide how this is being implemented. Thank you. That's my question.
Thank you very much. I'll first take one or two more questions, and then we'll have responses. Francois? Francois, are you able to unmute and ask your question? In the meantime, I'll ask Rina to take note of the question that was asked on the strategies. Francois, are you able to unmute your mic and ask your question, please? Okay, can we take Benjamin?
Permission to? They've all been given permission to unmute, so they just have to do that.
Bonjour.
Bonjour.
Ok, je pense bien que vous m'écoutez très bien. Je suis Benjamin de la RDC. J'avais une question par rapport J'ai une question par rapport au vaccin. Malheureusement que je vous ai suivi en cours de route. Je ne sais pas si vous avez déjà parlé. Je voulais avoir une information sur le vaccin. Si quelqu'un qui a présenté déjà les signes ou bien qui était confirmé de Mpox, est-ce que cette personne est éligible pour prendre le vaccin encore pendant qu'il a déjà fait la maladie? C'était ça vraiment ma question. Merci beaucoup.
Thank you very much, Benjamin. I'll ask Rina to respond to some of these questions. But let me, yeah, I think those are the hands we had. Rina, if you could respond to some of those questions that have been put across.
Yeah, sure. Hopefully you can hear me. I didn't get the last question. It cut out, but I did get the question about strategy. So what we recommend, especially in phase 1, during the outbreak phase, is to look at the local epidemiology down to the lowest level and identify hotspots where you can vaccinate those at high risk. So that might be contacts, that might be healthcare workers who are at risk of repeated exposure, and other key populations such as sex workers, MSM, and others with multiple sexual partners per the SAGE recommendations. So just to reiterate, looking for those areas where there are concentrated number of cases and focusing on those areas in this time when we have limited supply of vaccine doses. And I think that answers a few of the questions in the chat.
Okay, thank you, Rina. And Benjamin was asking if we need to vaccinate people who are already sick or who already have the Mpox.
So no, it's not recommended to vaccinate anyone who's already recovered from Mpox or is sick. Just like with any vaccine, we don't recommend giving any vaccine to anyone who's ill at that time.
Okay, thank you. I don't know if we have any other hands before we can go to the questions in the Q&A chat box. I think we are running out of time. I have a question for Tim. What is the governance structure of the AAM? Maybe I can first go through the questions and see who will answer which so that you answer them at once. So for Tim, what is the governance structure of the access and allocation mechanism? Then there's a question on, do we have the Mpox vaccine available for Africa? If yes, when will it be available for use? Maybe Tim can respond to that as well, or Rina. Then considering the lessons learned from COVID-19 pandemic, what innovative supply chain or allocation mechanisms are being applied to avoid bottlenecks in Mpox vaccine distribution and ensure timely delivery to at-risk populations? And are recommendations available for concomitant use of MVA-BN with other vaccines? The lack thereof is jeopardizing other vaccination interventions. So maybe Rina will take that.
Oh, thank you. So maybe I start, and on the question on the governance. So on the governance of the AM, I think I show the slide with the key partners, but these are concretely Africa CDC, WHO, UNICEF, Gavi, CEPI. I think these are the key partners that form the governance of the AM structure. When will vaccine be available? So the first deliveries has already been taken place. About 265,000 doses of vaccine have been delivered to DRC and Nigeria. And I think, Sheila, you also showed some of these also shared with Rwanda. So vaccine is already on the continent. Of the pledges that have been made, these are pledges, so they need to be formally, finalized with contractual agreement. So from now till the end of the year, there is likely 5.9 million doses will be coming down their pledges, and then we are working now with the partners and with the contributors, donors, to streamline and organize the delivery of these vaccines at certain points throughout the next couple of months. Over.
Thank you, Tim. Rina, would you like to come in on some of the questions?
Yeah, I think there was a question about administering multiple vaccines at the same time.
Yes.
So I'm not sure that SAGE has discussed this at this stage. Can you hear me okay? I don't want to entirely answer that we needed to better understand if we could we can get back to you on more information. I think there was also a question for the PQ folks from Sarah in our last minute that I think would be a good one to answer.
So for the PQ colleagues, hi, I'm Sarah. I'm a journalist from DEVEX. If a product has WHO pre-qualification, does it also need emergency use authorization within a country? What processes are required in a country before it can be used?
Well, the pre-qualification is a recommendation that we give that can be used by UN procuring agencies and also some member states. However, it is the country decision, and in fact, the pre-qualification, and this is what Marie indicated, the pre-qualification can leverage the authorizations in countries, but it's the country's decision to, let's say, provide the best pathway that in accordance with the country regulation for any specific authorization or permission for using the vaccines. So in principle, when we did the COVID-19, that we facilitated the authorizations in low middle income countries at a global level, the countries we saw a variety of countries following different pathways for the authorization. And this is also connected with, in our particular case, the PQ, we follow what the data is available, and then we decide the pathway. It will be the country's sovereignty to decide what pathway they are going to use. Probably Marie can complement on this.
No, fully in agreement. So there is the sovereignty of the country, obviously, to authorize the use of the vaccine. And we promote reliance in terms of using some of the work and evaluation done by others. But obviously, it's for the country to issue the authorization for use or the emergency authorization or any authorization the way they want to give it for use of the vaccine in the country. Thank you very much.
Okay, thank you very much to our panelists.
Let me add more to this particular question. In this instant, all the countries involved are involved in doing a joint review of the dossier with the pre-qualification with all the information. This is what I mentioned. And so in the coming days, the countries will be able to make the decision based on their regulations because their reviewers are currently working on this. So it is already in process. Thank you.
Okay, thank you very much, Kwasi, and thank you to all our panelists today. We still have a couple more questions in the Q&A chat box. Unfortunately, we are a few minutes past the time for ending the webinar, and we apologize for that, but we'll make sure we respond to all your questions, and the responses will be shared along with the webinar recording and the presentations from today's webinar. So I would call upon Sam to give a few closing remarks as well as we conclude this webinar. Thank you very much for your discussion.
Thanks so much, all. Thanks to the presenters and also to Sheila as chair. I will keep it relatively short, just 30 seconds because of the time. I wanted to thank everyone for your active participation on this call today. We've covered a number of key developments from the pre-qualification of vaccines to reflecting on the supply outlook and the access and allocation mechanism. So all of these together are critical pieces of information to ensure that countries have the information they need to understand how to maneuver and move forward with vaccination as one part of the response. Vaccines alone are not the complete solution, but they will be vital in some countries in some areas. And despite the limited supply, targeted interventions can help us use these resources efficiently, focusing on high-risk populations. The progress we've made on pre-qualification and allocation is significant, and we're very grateful to have the time and opportunity to share this information with you today. So again, I just want to thank everyone from governments, partner organizations, WHO, and so forth for your commitment and for your interest. The insights and strategies shared today will help guide all of us in a more coordinated response, and I'm confident that we can achieve meaningful impact together. So thank you again for your time and dedication, and I hope you have an excellent day.
Okay, bye everybody. We'll see you at our next webinar. Thank you for joining us.
Excellent. Have a good day.